The next discussion part is the sensory, how the information travels upwards. Okay, what you try to do is basically the sensory information is coming from the skin. It's also coming in from other, like the motor sensory fibers, and it carries information back to the spinal cord via the dorsal root eventually. These kind of systems can be actually broken down into three separate individual sensory systems. Pain can't differentiate from temperature. It's basically in the same track. It's also proprioception and stereognosis, which is the ability for the muscle to know where it's at in the environment, and how much stress load is put on the muscle is critical. And then light touch is the other sensory system that's involved. Pain and temperature, when it arrives in the dorsal column, goes to lamina 2, and then it crosses over almost immediately to the opposite side. The reason it's doing that is because it wants to be able to control spinal cord reflexes that also control the extensors on the opposite side. Okay, so if your foot steps on a nail, you want to be able to activate the other side of the spinal cord. That's why it immediately travels to the opposite side, so it can send that information to allow you for extensor contraction and flexor contraction on the ipsilateral side. It's basically, it carries that information up to get integrated into the thalamic system, okay, by the spinal thalamic tract. Okay? So when you look at it from the point of view of the actual, this drawing, which is what I want you to memorize, okay, it shows you that it comes in through the dorsal root, okay, and then eventually comes back up and goes into the thalamic area of the brain. So the thalamus actually takes that information and then decides what should actually get to the cortex and be modulated. Okay? That's your pain and temperature. Your proprioception and stereognosis, on the other hand, crosses over late. Okay? Because there's really no reason to give information to the opposite side. You're not going to base your weight lifting that you're doing based on what the other leg is doing. So you want to know what that leg is doing. Okay? So it provides other muscles in the same leg with information and feedback about the overall tone that's affecting possibly a muscle in that area. Okay? And it uses what's called the posterior columns to send that information up and down. Okay? You can see here it ductisates way late. Okay? If you look at it here, it goes up all the way to the brainstem before it ductisates, which means it flips to the opposite side, and then it reaches the cerebellum, the thalamus. Now, the reason that it ductisates late is that it may also send fibers to what? If you're trying to do fine motor control and you want to know where your leg is at in space, what is the system that's involved that doesn't have really a voluntary control mechanism? The cerebellum. Okay, so these columns also send information to the cerebellum of what's going on with that muscle group. Okay. The proprioception and stereognosis, which is an unconscious portion, which never ever crosses over, which means it never goes to the thalamus, okay, provides information directly to the cerebellum, okay, which is what I'm showing you here. Okay. These are called the spinal cerebellar tracts. Okay. The spinal cerebellar tracts are directly connected up to the cerebellum, and then they give you that efferent stimulus effect onto the motor to cause the effect that it does. Light touch crosses over later. Okay, it crosses over later, and it also provides local feedback controls to the muscle. It also crosses over early, so it has both things. Okay, so light touch it goes up both the posterior columns and the spinal thalamic tract. That makes a double of the signal to be sent to the thalamus. Okay, which means that light touch is actually very difficult to knock out, and it is. Okay, it is one of the most difficult things that you encounter when you take care of somebody in the operating room. You can easily knock out pain and temperature, but sometimes people can feel light touch and it freaks them out. They can actually feel the surgeon touching the skin, and they think it's going to cause pain, and it doesn't. But because psychologically they can't, they don't want to feel anything, and they immediately convert that to pain and they start screaming, even though it's not hurting them. Okay? So light touch can actually be very difficult to block. What we use in that situation is sometimes we use suppression using narcotics to inhibit that activity from taking place. The cranial nerves, there's 3 that are purely sensory, there's 4 that are motor, okay, and there's 5 that are mixed, okay. The olfactory nerve, which is cranial nerve number 1, is purely sensory, okay. It directly connects up and does not go through the thalamus at all. And then you have optic nerve, which is also purely sensory, which goes directly to the optic nerve. It's the occipital area of the brain. Then you have oculomotor and trochlear, which is cranial nerves 3 and 4. These are all part of the midbrain portion of the brain. That's responsible for controlling eye muscle movements, not all of them, but most of them. Then you have cranial nerves number 5, 6, and 7. That's the trigeminal, which is skin, sensory with some motor. And you have abducens, which is responsible for motor control. The eye is abducting. And then you have facial, which controls both motor and sensory. In the cranial nerve number 8, you have vestibulocochlear, which is, of course, your sensory, which allows you to hear, which is number 8. That goes to the temporal lobe. After it goes to the midbrain, the pons area of the midbrain. Then you have the next set, which is all in the medulla oblongata, which is the glossopharyngeal, the vagus nerve, the accessory nerve, and the hypoglossal nerve. The hypoglossal is mostly responsible for the tongue motion. The accessory nerve has to do with the ability to do the platysma motion in the front of the muscles, some other accessory muscles to the neck. The vagus is a mixed nerve. It has both sensory and motor, okay, which is critical, which makes a lot more sense once you understand that you can actually cause vagal stimulation and get a severe vagal reaction with a severe drop in heart rate from it. This is where the cranial nerves all go. It shows you the different components. Okay? Showing the first 4 cranial nerves are up in the midbrain, followed by 4 cranial nerves that are trigeminal nerve, facial nerve. Okay, you have your vestibulocochlear nerve and your glossopharyngeal nerve are all part of the pons. And then you go down into the medullary area, which is the vagus nerve, accessory fibers, the hypoglossal, and also your glossopharyngeal, which controls also the tongue. Now, this picture shows you how the actual nerves all come together. So you have both afferents and efferents traveling together as a nerve. Eventually they reach if they're an efferent, they'll reach a motor endplate. If they're an afferent, there's sensory information that's coming back. In this case, they're showing you the sensory, which is right here in the motor endplate. But they don't show you here that there's also a sheath where the afferents would come back to the posterior columns. The dermatomes is what I expect you to memorize for your exam. Okay, this is not going to go away. This is going to come back over and over again, so you might as well start memorizing dermatomes if you've never done so before. Here's how you remember the first one. C6 is this motion. This is the number 6. Okay, so the ability to take your thumb and oppose it to your index finger is due to C6. If you lose that ability, you lose C6. And that's the OK sign. Okay, so OK sign, also number 6. So that's C6. T4 is your nipple line. Okay. T10 is your umbilicus line. L1 is your inguinal line, inguinal ligament. Okay. Then you have S1 is your foot, the back of your foot. Okay. And the S4, S5 is the rectum, the anus. The best way to remember that is by looking at this way. Okay? If you think of us as being 4-legged animals, instead of trying to memorize it this way, which is difficult, okay? If you think of us as being 4-legged animals, you can see that we're just basically laid out straight down from the spinal cord, just like that, okay? Which sort of makes more sense. And it shows you why the rectum is S4, S5. Okay? We're basically, that's our tail end of us, not the legs. Okay? Make more sense? I hope so. Okay? The protective structures that protects the central nervous system is, of course, made of the skull. There's 8 bones in the skull. The frontal, occipital, temporal, parietal, sphenoid, and ethmoid. I don't expect you to know all the different bones and foramen and all that stuff. It's something you do in an anatomical class and spend a lot of time with. The cranial vault, which is the bottom floor of it, is composed of 3 different sections. The anterior fossa, which is where the frontal lobe sits. Then you have the middle or temporal fossa, which is where the internal carotid arteries are coming through. Okay? And then you have your posterior fossa, which is responsible for the brainstem and where the cerebellum are located at. The meninges are protective membranes surrounding the brain and spinal cord. The dura mater is the outermost layer. There's actually a dual layer of thickness on your skull, okay? Followed by the arachnoid, which is next, and then you have the pia mater. The pia mater eventually forms the choroid plexus, and the choroid plexus is responsible for the production of CSF. Okay? This is a nice picture showing you how the skull is followed right underneath it by the dura mater, followed by the arachnoid and the pia mater. And your brain is actually protected also by cerebral spinal fluid that's all the way around it. So your brain is basically in a fluid medium, so it's floating inside your skull. And that's important because if you understand that, that's why when you walk around it doesn't jar your brain, it doesn't cause any problems to it. Okay? The cerebral spinal fluid in the ventricular system accounts for about 125 to 150 cc's of total volume, so it's not very much. It's produced by the choroid plexus in the lateral third and fourth ventricles. The lateral ventricles are also considered lateral ventricles 1 and 2, which are in this portion of the brain. I'll show you in a minute. Followed by the third ventricle, which is in the middle, and the fourth ventricle, which is down and leading out around the spinal cord itself. Okay? The brainstem itself. The CSF is produced inside the actual ventricles and then reabsorbed via the arachnoid villi in the superior sagittal sinus. Okay, so here's how the CSF is produced. CSF is produced from inside these actual holes inside your brain, okay, which we call the ventricles. Okay. There's one on each side, which we call, that's part inside the hemisphere. That's called the lateral ventricles. Okay, we should also consider ventricle 1 and 2. And then the middle portion right here, okay, where it all combines, is the third ventricle. Okay, the third ventricle is then opens up via a small little duct here. It goes down into the fourth ventricle. Okay? And once you get into the fourth ventricle, you get to different openings, which is lateral ones are Luschka, and the one in the middle is called Magendie. Okay. Next thing is blood supply to the brain is actually quite considerable amount of volume. We're looking at 800 to 1,000 cc's per minute. That's a lot of volume. Okay. CO2 is a primary regulator of central nervous system blood flow under most circumstances. Mean arterial pressure between 50 and 150 maintains a steady cerebral blood flow. But if you increase CO2 levels, it immediately causes an increase in cerebral blood flow. Okay? If you decrease CO2 levels below normal 40, then you get cerebral vasoconstriction. Eventually, when you reach a CO2 of 20, you cause such intense cerebral vasoconstriction that you can actually stop all blood flow to the brain, which is very dangerous, to say the least. Okay? Now, the other mechanism that also controls blood supply to the brain is hypoxia. Okay? If you get below 60 millimeters of mercury in the PaO2 at the brain level, it actually causes vasodilation to take place to try to increase cerebral blood flow. Okay? So one of the things that is protective of the brain is when you're actually becoming hypoxic, you actually increase blood flow to that portion of the brain. Okay? Now what's important about that too is that it actually, which one's a primary, is it CO2 or hypoxia? Hypoxia almost never happens, so it's usually not the primary mechanism. But if you have to say which one is stronger in effect, it would be if you hyperventilate somebody and you cause them hypoxia, the hypoxia would take over. Okay, the hypoxia is a more potent mechanism of causing cerebral vasodilation. So if you induce hypoxia in somebody that you're hyperventilating, if you're affecting the lung function inappropriately, you will begin to increase cerebral blood flow back up again. The internal carotids break up into the middle cerebral as well as the anterior cerebral artery. The middle cerebral artery goes along the lateral aspect of the frontal lobe and basically controls the upper motor neuron, upper body effects. The anterior cerebral artery then runs between the hemispheres and provides the blood supply to the lower extremities. That's why you get the lower extremity weakness from an anterior cerebral infarct. Clinical problems with carotid occlusion is you get weakness and loss of sensation to the contralateral side, and you also lose motor control as well. You have two vertebral arteries as well that provides blood supply to the brain. These two vertebral arteries eventually join and form what's called the basilar artery, and then that actually forms the posterior communicating artery, and then it begins to bind via the loop of not Henle. Yeah, loop of Henle. Not loop of Henle. What's it? Oh gosh, I remember in a second. Anyways, there's a system in place in your brain that actually allows you to get blood supply from the vertebral arteries when you get occlusion of the carotid, called the collateral flow. Okay, that's called the circle of Willis. Okay, the circle of Willis actually allows losing one vertebral and still not causing an infarct in that area. So all these are important collateral mechanisms, which I'll show you, and that'll be part of your exam as well. This is the actual structure that you're looking at. When we talk about the cardiovascular section, we'll go into the different portions of the blood supply that are eventually reaching the brain. But know that the internal carotid artery is actually what supplies the internal portion of the brain. It's the external carotid artery that provides the external portions of the face and portions of the neck. Okay? But the internal carotid is what actually provides the middle and anterior cerebral arteries. When you break it up into area zones by this color, it can actually tell you exactly what areas where you get infarcts from. And if you see a middle cerebral infarct, you'll see the loss of sensory and motor to the hand and face. But if you get the anterior cerebral artery gets knocked out, you lose the control of the legs, okay, on the contralateral side. Okay. You still have intact sensory, by the way, with the stroke of the legs. You tend to have just motor loss in the legs. This shows you the occlusion of the posterior cerebral artery, how it's very detrimental to the occipital lobes. It may actually cause cortical blindness in this person. So somebody who has a posterior cerebral artery occlusion due to embolus or something like that, you then get actual occipital blindness. The circle of Willis is expected for you to memorize. Okay? What I call him is the angry spider. Okay? The angry spider because of the number of legs he has. Okay? How many legs does a spider have? 8 legs? 6 legs? Okay. He's got, I think most spiders have 6 legs. That's the last time I looked. Okay? Or am I wrong? I thought I saw him with 6 legs, but okay. They call him usually the angry spider. Okay? So here's what he has. Okay? He's got 2 eyes, okay, which is the eyes are basically the carotid arteries coming in, which is the internal carotid arteries. They provide the antenna in the front, okay, and then the mandible in front, and then you see the first leg, okay, which is this is the middle cerebral artery and the anterior cerebral artery. Okay. These anterior cerebral arteries connect to each other via what's called the anterior communicating artery. Okay. So this gives collateral flow from the opposite side. Okay. And that's why it's called the circle. You see how it goes around in a circle? A green is a circle. Okay. The structure in the middle here, which gives it the bearded look, okay, or the funny eyebrow look, is the optic nerve, the optic chiasm. Okay, it's located here, and the mammary bodies are down here. Okay, you can actually have the posterior communicating arteries connect up between the posterior portion of the internal carotid artery directly to the basilar artery. Okay, and this what gives you the ability that if you do lose the vertebral or basal arteries, you can still get some collateral blood flow from the internal carotid arteries to that back portion of the brain. Okay. The vertebral arteries connect up together, okay, eventually forming what's called the basilar artery right here in the middle. Okay. That basilar artery also forms the posterior cerebral artery, which provides the occipital lobe area of the brain. Okay. The basilar artery is extremely important for what portion of the brain? Brainstem. Okay, so the brainstem is being provided by basilar arteries significantly. Okay? If you lose the basilar artery, you're going to be in big trouble, okay, most of the time. The blood supplied by the spinal cord is a little bit different than the brain in the sense that the aorta provides most of the blood supply to the spinal cord. Sometimes also vertebral arteries are considered part of the spinal cord blood flow, which is the anterior spinal arteries and posterior spinal arteries originating from the vertebral arteries. But most of the thoracic and lumbar area is provided by the blood supply directly from the aorta through posterior branches that go through perforating arteries in the posterior aspects of the aorta. Okay? This is a nice picture showing you the actual blood supply to the cervical arteries, okay? Showing that you're supplied into these internal spinal arteries. Now what's important about this is when we talk about regional anesthesia, we're going to talk about epidural hematomas and how they affect a patient. The anterior spinal artery, which is here, provides a triangular region of blood supply to the anterior motor elements of the spinal cord. Okay? So if you were to lose in the anterior spinal artery, you would lose the ability to move below that point. Okay? On the other hand, your motor, your sensory is on the posterior elements, and that's covered by two posterior cerebral arteries, two posterior spinal arteries that provide the oxygenation and reuptake the metabolism from that area. Okay? So these posterior spinal arteries, there's two of them. So that means they're more redundant, so they're more resistant to compression. So when you cause an epidural hematoma, which is when you bleed into the epidural space, you begin to pressurize the epidural space and push the spinal cord forward, and then you lose the blood supply to the anterior spinal artery. So what would happen if you lose the blood supply to the anterior spinal artery? You get paraplegia. Okay? You can lose muscle functions of the lower extremity. You still have intact sensory, though. So the person can feel everything, but they just can't move their legs. Okay? For cerebral physiology, the brain is basically basically a fixed compartment. 84% of the brain is taking up that space, of which 12% is CSF, and the smallest fraction of all is blood, which accounts for only 4%. If you increase one, the other one is going to either have to be displaced or the pressure is going to have to build up. Okay, so it's one or the other. Now, the body has a certain ability of having what's called compliance. Okay, it has the ability to allow some expansion to take place without any deleterious effects of increasing pressure inside the skull. And that's called the compliance curve. The point between 1 and 2 is in normal compliance of somebody who's got a healthy brain. This line 1 would be extremely, go out further out if you have somebody who's an alcoholic. Okay? Because the actual space between your brain and the skull is actually increasing as you become increasingly more intoxicated, and because you destroy more brain cells. So instead, you have more ability to go this way before your actual pressure begins to go back up. So, alcoholics. Now, the reason that's important to know is if you have somebody who comes in and he's just smashed his head against the floor, and he's 24 years old and he's a healthy kid with a very nice normal brain when you do a CT, he's going to have much faster symptoms than a person who's 60 years old who took the same impact, who had been drinking for the last 40 years, and his brain is about 1/3 the normal size. Okay, so now that person's brain will be able to absorb that bleeding easier with no symptoms. They'll be sitting there looking at you and talking to you and be totally normal. Versus the same bleed in a 24-year-old with a tight brain would be dying. Okay? Because of volume displacement in that situation, that compliance curve is different for different disease states. Okay? Now, once you start increasing the pressure, once you start going up this curve, bad things happen. It's not so much the pressure that kills you, it's an indication that volume is getting too big for what the case inside the case that's holding it. So what happens is the brain will begin to basically evaginate outwards or cause it to herniate outwards and cause a person to lose function in that portion of the brain. Okay? That person will then, of course, die. It's not the pressure that herniates the brain, it's the volume. Measuring volume, unfortunately, is difficult, but one of the things that we're doing nowadays for taking care of patients is that we're actually now putting CT scanners in the actual ICUs to monitor them more carefully. And what we actually do for monitoring is we use intrapressure pump monitors, and we're now putting a lot more intraventricular catheters in place, so that way we can draw off CSF and relieve some of the volume which then drops the pressure back down. So we're actually doing something therapeutic by doing that. Now, cerebral perfusion pressure is a fact of just simply the difference in mean arterial pressure minus your intracranial pressure. The normal cerebral perfusion pressure should be around 90 millimeters of mercury, okay? And it doesn't become ischemic until you get below 50 millimeters of mercury. So 50 is really your cutoff point. And the reason that you're using your mean arterial pressure instead of when we talk about the heart is because the blood is supplying the brain throughout both systole and diastole. So the most accurate measurement of cerebral perfusion pressure is the mean arterial pressure minus the ICP. The mean arterial pressure, what I expect you to know for the test, is that it's composed of many different components. It says cardiac output, systemic vascular resistance, blood viscosity. It also is due to the elasticity of the conducting arteries and also due to the dynamics of pulsatile flow. It's also this equation that I expect you to memorize. It's not going to go away. This is another one of those equations I do definitely want you to know, which is diastolic pressure plus, in parentheses, systolic pressure minus diastolic pressure times 3, and that gives you the mean arterial pressure. The ICP is due to changes in volume in the brain, CSF, or increases in blood flow. And you can control ICP by controlling either CSF volume or by decreasing cerebral blood flow, although it's not recommended to decrease cerebral blood flow too much because then you get more ischemia of the brain. Okay. Cerebral blood flow is something that we theoretically talk about in class, but it's something that's very difficult to measure because it's very difficult to measure anything in living beings with cerebral blood flow, okay? Because it's hard to measure flows, okay? So this is more of a concept that you have to understand, okay? Cerebral blood flow has to be related very much with cerebral metabolic rate of oxygen consumption. If you increase cerebral metabolic activity, cerebral blood flow has to be increased, okay? Which is what I talked to you about earlier. I told you that different portions of the brain will get different degrees of blood perfusion depending on how much activity it is. It simply has to do with cerebral metabolic rate of oxygen consumption. Now, the reason that's related to that so strongly is because when you increase cerebral metabolic oxygen requirements, what do you produce as a side product of oxidative phosphorylation? CO2 and water. Very good. When you produce CO2 like that, it causes cerebral vasodilation, and in consequence causes shunting of blood of that area. So it simply has to do with metabolism increasing, producing more CO2, and then more blood flow goes to that area, and that was what we measure as cerebral blood flow. Okay. It opposite also applies when activity is increased, okay, which means that as increased activity, cerebral blood flow should increase as a consequence. Now, the next concept also is cerebral blood volume, which is a very small amount. Cerebral blood volume only accounts for 4% of the total volume inside your brain, which accounts for a total of 60 to 100 cc's total that's in the brain. That's not a lot. But what people don't understand is they think that it's the volume that goes through there, and actually it's not. They're actually going through per minute is 800 to 1,000 cc's per minute. That's different, and it's different than volume. Volume is actually limited, but if you've ever seen somebody get a gunshot to their head, it's unbelievable how much blood you lose, and it's very quickly. Okay? In 3 minutes, you're dead from exsanguination. Okay? So cerebral blood volume, on the other hand, is actually a very small volume. It accounts for only 4% of the total volume in your brain, which is only 60 to 100 cc's. It's a rapid turnover that makes a difference in this one. Now, the cerebral blood volume can actually be altered by different situations. If you if you make the temperature go up, in other words, you give the person a fever, okay, that will actually increase cerebral blood volume. If you have the person be more awake, they have increased cerebral blood volume. If you put somebody upside down, their cerebral blood volume will also increase. Okay? And we're not like bats. Bats have one-way valves that allow them to sleep upside down. We don't have that. Okay? And if we sleep upside down, you'll hemorrhage into your brain in 6 to 8 hours if you sleep upside down like a bat. You won't do well. Okay? Your body will be screaming at you pretty quickly that you're having severe pain. They've had some people actually fall through a roof they were trying to steal and a garage, and the guy got caught in a rope, and he was found dead the next day because he hemorrhaged into his brain. Not from the impact of the fall, is that simply he was upside down for such a long period of time and he couldn't get himself out of it, and he basically ended up increasing the intravascular volume and basically hemorrhaging into his brain. So it's not something that's healthy for you. And also it's important for us when we put people in deep trundumbar position, we're causing cerebral edema to occur. Okay? So if you have somebody with prolonged, let's say you're doing robotic surgery for 8 to 12 hours, that person's brain's going to be a little bit scrambled. And when they wake up, of course they're going to blame it on anesthesia. They're going to say, it's the anesthesia's fault the patient's not waking up. And I'm going like, well, yeah, it could be that you put the person in trundumbar for 8.5 hours, and they've been like a vampire. Okay, not quite the good idea. Okay, so, and some people with membranes that are actually thin, they may actually hemorrhage, and you might have a big problem on your hands. Okay. Blood pressure, of course, the higher the blood pressure, usually the more volume there is in the brain. And carbon dioxide tension is critical too. The higher the CO2 levels, the more blood flow there is, so there's more cerebral blood volume as a consequence. Cerebral blood volume is the total arterial and venous structure, which approximately accounts for about the internal carotid arteries about 80%, and vertebral basal arteries are actually 20% of the total blood volume. So the vertebral basal system is critical, but it actually is the least amount. This is why, when you look at this from the standpoint of propofol, when you inject it, why it attacks the cerebral cortex so quickly. Because a lot more blood volume is located in the aortic cortex. So the person goes to sleep very quickly, cortically, but their actual spinal, their brainstem actually is lower in onset. So because the vertebral basal artery, which only accounts for 20% of the volume, is taking a longer time to get there. Okay? Cerebral blood flow versus function. The normal cerebral blood flow should range between 45 to 50 cc's per 100 grams of tissue per minute. Once you start getting below 20, that's when you start seeing EEG slowing. Once you get down to 15, you're now getting some sensory evoked potentials are being affected. And at nil function below 6, okay, you may have some survival, but you get irreversible cell death once you get below 6 cc's per 100 grams per tissue per minute. The control mechanisms of autoregulation are critical. Carbon dioxide tension and oxygen tension and temperature. Okay? This is where I want you to be. This is what I expect you to know for your exam as well. We'll almost stop here. We've got 3 more minutes and we'll stop. The linear relationship between CO2 and cerebral blood flow should be clearly understood. This is not going to go away. This is all part of neurophysiology. And this is a favorite that everybody asks on boards as well as exams. The good thing about it is that I'll hit you on this now. I'll hit it again on you in pathophysiology, and we'll hit it again in coexisting. So you're going to get it, and then trauma again. So I make you memorize this over and over again because it's so critical. Okay? What this is showing you is there's 3 different variables. Okay? The X line is measurement of pressures, usually in millimeters of mercury. Okay? And that means the mean arterial pressure. It also has the PaO2, which is millimeters of mercury, and also the PaCO2. So all those X lines, depending on which agent you're looking at, that's still in millimeters of mercury. On the other hand, the Y plane is on the cerebral blood flow plane. Okay? It indicates to you how much cerebral blood flow is going to that portion of the brain. Okay? If you're looking at the first port, which is carbon dioxide tension, that's a linear relationship between cerebral carbon dioxide and cerebral blood flow. As CO2 becomes increased, okay, it goes from, let's say, 40 to 75, the actual person's cerebral blood flow is increased from 50 milliliters per 100 grams of tissue per minute to 75 milliliters per 100 grams of tissue per minute. So you're going up this curve. So as you increase as you increase CO2, you increase cerebral blood flow. The way the brain looks at it is that if you're increasing cerebral blood flow, if you're increasing CO2 levels, that my metabolism's kicking up and I need to wash it out. And you need more oxygen, so it increases cerebral blood flow to that area. Okay? So there's for every 1 cc of cerebral blood flow, for every 2 millimeter rise in CO2. Okay? And what it does is it causes cerebral vasodilation. And that cerebral vasodilation is particularly prominent when you're letting somebody hypoventilate in the operating room, which is something we do normally because of anesthetics suppress the central nervous system CO2 response curve. And as a consequence, the person's CO2 runs in the 50s during the case. These people complain of severe headaches a lot of times post-operatively simply because of this increased vasodilation in the brain. The other one is oxygen tension. Oxygen tension, you can see this other dashed line is normal. Okay? There's no effect of oxygen tension as long as you're above 60. And then once you hit around 50, it's a linear, very rapid increase in cerebral blood flow. So once your PO2 values drop below 50, the body vasodilates the brain significantly. It actually can offset the effects of hypercarbia and actually accentuate the response. So even if you were to hyperventilate somebody and drop their CO2 levels very down, very low, if you would cause them to develop hypoxia, the brain will vasodilate to try to compensate for that effect, which it becomes more important. Okay? And the last one I talked to you about here, and then we'll stop, then we'll start up next week, is the mean arterial pressure. The mean arterial pressure between 50 and 150 is normally unchanging. So as you move up on the pressure, okay, you would vasoconstrict the brain to try to maintain the same cerebral blood flow. Okay? It is only once you get above 150 millimeters of a mean arterial pressure that you begin to cause vasodilation and increase in cerebral blood flow. If you drop below 50, if you drop below the 50 value, then you will cause a decrease in cerebral blood flow, and the brain will start to try to vasodilate to try to maintain blood flow, but it can't. So you'll see a drop off in mean arterial pressure drops off in mean cerebral blood flow. Okay? This will we'll stop here for today, and next week we'll start back up on this and then finish up on the other two sections.